Austin and UT Dell Medical School, and happy to talk to you about a topic that comes up quite a bit, which is a hodgepodge of topics that I all put under the umbrella of 10 things I get asked about the aging brain and a few answers to those questions. So most of the questions that I'll cover today are coming from the world of kind of difficulties that happen with the aging brain and things like cognitive impairment and dementia. But certainly we can talk about kind of normal aging processes too, or other questions that you have at the end here. I will try, there we go. So no big disclosures here. I do work for UT Health Austin. I'm a researcher as well as a clinician. I'm a clinical scientist, so we're not going to talk directly about my research unless y'all want to, but do want to thank my sponsors for that. And these are kind of my opinions today, and this is not a replacement for talking to your doctor, and that's going to come up several times. This is not medical advice. This is information, and ultimately get medical advice from your medical providers, okay? All right, so one of the first questions that I get asked and that I have to explain all the time is, I'm a what is a neuropsychologist? Okay, so this is hopefully a profession you may not have heard much about before, but a neuropsychologist is a PhD. So I'm a PhD, not an MD, all right? But just like how your physicians go and get a general medical school degree, and then they specialize in a particular area. So they go to med school and become a neurologist or a psychiatrist. In psychology, we do the same things. We go to our graduate school in kind of general clinical psychology, and then we specialize. And so a neuropsychologist is a psychologist who specializes in measuring things like memory, attention, language, those cognitive processes. So we measure, and then we help use those measurements in people that have neurological conditions to help guide diagnosis and treatment planning. So that's what a neuropsychologist is. So at UT Health, I'm one part of what Rocky had mentioned as the Comprehensive Memory Center. And it's a comprehensive memory center because when you're dealing with conditions that affect the aging brain, it really does take a team of people to try to get diagnosis and treatment plans going and get it set up. And so on our team, we have neurologists, right? Those are physicians that specialize in the nervous system. We have psychiatrists who are physicians who specialize in, especially in medical treatments and diagnosis of kind of behavioral difficulties. You have neuropsychologists like me. We measure cognition, memory, attention, that sort of thing. We've got nurse practitioners, who's a nurse who has advanced training that allows her to manage patients' health. We have speech language pathologists who help us work with producing therapy plans and interventions for memory and other cognitive problems. We work with social workers who help work with family members and access community resources. Clinical pharmacists who help us understand all the interactions of medications, and even more team members. We have CMAs and psychometricians and research assistants. So here at the CMC, when we're addressing these problems that can come up with aging, you really will hear us talk a lot about the team because each of us bring our own specialties to the table to help arrive at diagnoses and treatment plans. Okay, so probably after I explain what the heck a neuropsychologist actually is, the next most common question I get asked is, what is dementia, right? And then the follow-up question, which will be next, which is, what is the difference between Alzheimer's and dementia? And understandably so, as you age and as you see friends and families and you yourselves have these changes, there's always this kind of terminology question. And so I think it's important to kind of get the terminology straight up front. So let's talk about first kind of what is dementia, okay? And when I explain this, when you kind of summarize this pretty complicated field, it really does boil down to kind of two things. So first of all, you have to have a change in thinking that's not just attributable to kind of the normal aging process. And that change in thinking has to make it harder to do day-to-day activities that you used to be able to do. Okay, so let's unpack that a little bit. A change in thinking. Change is inevitable whenever it comes to the brain. Your brain is just another part of the body. So it changes with age, just the way your muscle tone changes, your skin changes, your eyesight changes. Things change as you age, right? That used to be a clever thing I said in talks way back in the day. As my beard has grown more white, that becomes a more painful reality to recognize. You can get common changes with aging that include things like kind of slower processing speed and more difficulties multitasking. That happens for everyone with age. But when you start seeing changes in things like memory and attention, and on my sorts of tests, if those changes are more than what we would expect for your age and education, that gets our attention. But then if you also have to stop doing your day-to-day activities, or you're making more mistake in your day-to-day activities, things that can be complicated, like mistakes remembering to pay the bills, or mistakes with driving, or in later stages with problems with more basic tasks, having problems remembering to bathe or shower, those sorts of things. That's when you have those two things together, that is what pushes us over into a dementia type diagnosis. Okay. Now, the second part here, besides changes in thinking that lead to problems with day-to-day activity, is you have to rule out other causes that can cause those same things. So in other words, the brain is the end result of a whole lot of kind of different medical processes. Almost anything that affects your body can affect your brain. And so before you label something as a dementia, you want to make sure that there's not another health condition that causes changes in thinking or changes in day-to-day activity. And we'll talk more about that in a second. That's probably one of the more frustrating things patients tell me about, is it's such a long process to kind of get the diagnosis figured out. And part of that's because you have to rule out a bunch of other competing or contributing conditions. Another term you'll sometimes hear, and I think increasingly you're hearing more and more about it, is this idea of MCI, or mild cognitive impairment. And so in MCI, right, the difference between MCI and dementia is that in MCI, you have measurable changes in thinking. So again, you're having more problems than we would expect just based on age on my sorts of thinking tests, but you're still able to do all your day-to-day activities, right? So if you have measurable thinking problems, but they're not really interfering with day-to-day tasks, that's when we use an MCI label. If you have measurable problems in thinking and they're making it harder to do day-to-day activities, that's where we would use a dementia label, okay? That distinction is kind of important. And MCI has become a hot area of research and practice, because whereas most people, or all people that get dementia, will have passed through a mild cognitive impairment phase, not all people with mild cognitive impairment go on to develop dementia. And so there's been a lot of focus on these kind of earlier, milder changes, because those may be particularly important areas to consider intervening or modifying lifestyle factors, some of the other things that we'll talk about. But this is where kind of that earlier detection, earlier identification is kind of getting a lot of traction behind it as possibly a place we want to intervene, or at least be monitoring people closer. Along the way, when we talk about these terms like MCI and dementia and these sorts of things, it's important to kind of keep in mind kind of a rough staging here, and especially if you've seen people who have lived with dementia, or you've helped with other people who've had dementia. It's important to kind of keep in mind that all dementias are not the same, and there's kind of different stages of severity. And we stage the severity of dementia based upon how well a person can kind of live in their day-to-day environment. So I tell patients and families all the time, the real test is the real world, right? And so if you're fully functional day-to-day, despite some memory problems, probably looking at no more than a mild cognitive impairment. If complicated day-to-day activities, usually things like medications, driving, and finances are impacted, that's a milder stage of dementia. Moderate stage dementia is where those more kind of basic tests like dressing and bathing and showering may start to get difficult. And then severe dementia is where people aren't engaging in self-care. So not everybody with the dementia ends up going through all these stages. Different people get different stages at different mind points. But when you're talking about dementia, and especially if you've seen other people live through these things, keep in mind that no one person's staging is directly comparable to another one. There's a lot of variability even within that umbrella term of dementia. Okay, so the next question that you get all the time is making the difference or making the distinction between Alzheimer's and dementia. That is a question I would say almost every clinical interview I do, every assessment I see, I get asked this question. So let's talk about this. Dementia, like we talked about, is an umbrella term. It just means a change in thinking, right, that leads to day-to-day activities, okay? There are a lot of things that can cause dementia. Dementia has to have a cause, and a lot of things can cause a dementia, okay? So I think one of the unfortunate things over the last couple of years that we've had to learn is like that there's a difference between having pneumonia, right? You can have pneumonia, you can have a respiratory infection, and that pneumonia or respiratory infection can be caused by a lot of things. It can be caused by COVID. It can be caused by other respiratory viruses. So think about that as kind of an analogy. Dementia is the umbrella term, sort of like pneumonia is an umbrella term. And then you can go through different diagnostic tests to help figure out what's causing that umbrella condition, okay? So there are, the dementias are usually caused by microscopic proteins, right? Or structural changes in the brain, or a combination of both, all right? So when you hear the term Alzheimer's disease, when you hear the term Alzheimer's disease used, what you're thinking about is under a microscope, you would see these two proteins, this beta amyloid plaque and this protein called tau. Right, so if you have amyloid and tau, that causes the most typical or the most common dementia, which is Alzheimer's disease. And that's usually marked by having a lot of forgetfulness with other changes in thinking later. There are some variants. Sometimes those, because the brain is a lot like real estate, location, 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 right? Usually those proteins start over on the sides of the brain and the temporal lobes, which is where memory and language happen. But sometimes those proteins will pop up in the back of the brain and cause visual problems first. Sometimes they'll pop up in the front of the brain and cause kind of behavioral or multitasking difficulties first. But usually those proteins like to accumulate in the memory parts of the brain, and that causes the typical Alzheimer's. Another protein that can accumulate in the brain is what we call Lewy bodies, or they're actually clumps of something called alpha-synuclein, or the synucleinopathies. These are the proteins that cause Parkinson's disease. That's a condition I think a lot of people are familiar with. Sometimes those Lewy bodies start in the thinking parts of the brain first, and so they'll cause something called dementia with Lewy bodies. There's a few other kind of conditions that can be caused by this that are less common, but those Lewy bodies or Parkinson-type proteins can cause thinking changes as well. Vascular is very, very common. As you age, your brain is kind of full of these teeny tiny little blood vessels. And so folks who have risk factors for heart problems, things like high blood pressure, hypertension, hyperlipidemia, those sorts of things, they can clog off those little blood vessel changes in the brain. We all get some of that as we age, but sometimes you get a lot of that in a particular case, which can cause thinking problems. We call that a vascular dementia. Sometimes people have strokes and their thinking skills never really recover after that. We would call that a vascular dementia as well. Again, it depends on where and how much stroke changes you have to determine what sort of symptoms you have. Again, brain is real estate, location, location, location. So if you get a lot of stroke or vascular damage in the left side of the brain, you might have more language problems, more in the back, and on the right, you might get more visual spatial problems, more up front, multitasking problems, those sorts of things. There's also things called tauopathies. These usually happen to folks who are younger, right? 40s, 50s, 60s is when these conditions kind of come on. And so the most common ones are called frontotemporal dementias. They can be things like changes in the front of the brain that cause personality and behavior changes. Changes in the left kind of temporal and frontal parts of the brain that can change speech, known as the primary progressive aphasias. Sometimes they happen in the back and down low. That can cause movement problems, atypical Parkinsonisms like cortical basal degeneration or PSP. But those are all kind of in the tau family. And again, there's a bunch of other stuff that we're not going to cover today. There's stuff like normal pressure hydrocephalus, which is where too much fluid builds up in the brain. There's Creutzfeldt-Jakob, which is kind of a variant of called a prion disease, a proteinaceous infectious particle. HIV can cause a dementia, and on it goes. So again, when you think about that question, what's the difference between dementia and Alzheimer's, right? Dementia is the umbrella term. And then you go through the workup to try to figure out which of these things or what combination of them, because you can have more than one thing going on in the brain, is causing the underlying cognitive impairment. All right, so that almost inevitably leads to a question about how do you go about finding out if there actually is a problem. Okay, and so my key takeaway, if you take away nothing else today, if you have concerns about yourself, or if someone that you care for, you're friends with, your family with, if you're noticing changes, start with a good primary care workup. Okay. Remember that arriving at a diagnosis is a series of exclusions, right? We want to exclude other treatable things that can mimic these symptoms. So we want to do the basic stuff first because the basics matter, okay? A lot of things can mimic memory changes, dementias, these sorts of things. So stuff like untreated depression and anxiety, right? This is something I see very common that kind of mimics a dementia. If you think about your brain as kind of a pipe, right? Your brain can only process so much information through that pipe. And as you age, that pipe gets a little leakier just as a part of the normal aging process. Well, then if you start adding a lot of stress, depression, maybe you're grieving a significant loss, that sort of thing, those sorts of thoughts kind of fill up your pipe all the time. And it leaves you less room in the pipe to process other information. So especially as you age with depression and anxiety, it's not uncommon to have more problems with concentration and memory lapses, that sort of stuff. Very common. Things like abnormal thyroid, if your thyroid's really off, if your B12 is low, if your blood sugars are really kind of out of kilter. Blood sugar is the fuel of the brain. So it's sort of like having a car that's running too rich or too lean with the gasoline. You want to try to rule out those sorts of things because they can cause cognitive changes. A sudden change in thinking, you should always go see your doctor, but particularly because treatable things like urinary tract infections all the way down there can affect all the way up here, right? Because that feeling of being sick can kind of release these inflammatory markers and really lead the brain to kind of get confused in a hurry. Hearing and vision problems. This is one that everybody kind of grumbles whenever I talk about this, but having an untreated hearing problem will mimic a memory problem for a couple of reasons. One is if you don't hear it, you won't remember it later, or if you hear it wrong, you'll remember it wrong later, right? It also makes it harder to focus, right? You'll see people kind of check out of conversations, not be able to track the conversation. They'll look confused but it's because they're struggling. They can't get the information into the brain to process. And on it goes. So if there's a concern, right, start with your primary care doctor, because we want to start the process as quick as we can of ruling out other treatable things, right? Then if your PCP has kind of ruled out the treatable things or can't find anything else to look at, then you might get a referral to a specialty clinic like ours. There's a lot of people that see dementia as a part of their clinical work. So different neurologists, different geriatric psychiatrists, geriatricians, internal medicine doctors, a lot of different providers see a bunch of folks with MCI or dementia. In specialty clinic like ours, right, how it generally works is you see the team, right? I'll come back to the team. So that means you get a medical evaluation by one of our neurologists, psychiatrists, or nurse practitioners. You might see either me or my boss, Robin, who are both neuropsychologists, and we might try to measure those cognitive changes depending on what the difficulty is. We might order scans of the brain to make sure there's no kind of structural changes going on in the brain or any of those blood vessel changes that might influence cognition. Family members might meet with a social worker to kind of go through and get an idea of any needs that the family has day to day. And once we have all of that information together, we sit down as a group, and every case that's a new case through our clinic, we go over all the information and kind of get all on the same page about what we think is going on and what the best kind of treatment options would be for you. Once we're together as a team and we arrive at that, then you get a follow-up visit and you go over and you try to give all the information kind of in one sit-down meeting to go over everything together. We found that to be easier to digest oftentimes than kind of spreading it out like, oh, well, maybe let's start a medication, but I'll send you for more testing, and then we'll have a follow-up about that test, but then let's see how this next test goes, right? We try to kind of tie things up in a package here. Doesn't always work that way, but that's what we shoot for. All right. A word about imaging, because I think this is something that again, as a corollary to how I find out if there is a problem, is usually you might get sent for a CAT scan or an MRI if you're noticing memory complaints. And when when that report comes back, it might say things like an unremarkable scan for age or mild atrophy and mild white matter disease, that sort of thing. And so kind of something to keep in mind about MRIs and imaging in a dementia workup is that imaging is most helpful at ruling things out, right? You want to rule out other potential changes. So we want to rule out that you've been having silent strokes, or that there's a silent brain tumor, or any sort of enlarged ventricles that can be seen with some conditions. So MRIs help us rule some things out. They don't diagnose conditions like Alzheimer's disease, except in very kind of specific circumstances. There are starting to be some kind of special scans that come along. You'll hear stuff about PET, positron emission tomography, and amyloid PET. These have been around for a while, but they're getting increasingly used in kind of diagnostic workup for cognitive impairment. They still haven't really replaced the standard of care. They're things that we usually order in addition to, or if we're unsure based upon our other workup about the diagnosis. Another super, super common question that I get asked, all right? I had a family member that had dementia. Am I going to get it, right? I think this is a very common question that comes up, okay? And so I call this a simple answer. It's not really simple. This is an incredibly complex question, but as a rubric, as a kind of way of thinking about genetics and dementia, kind of clump two different things together. Early onset dementias. This is where someone was pretty obviously having declines in thinking and problems with day-to-day activities in their 40s, 50s, early 60s. That's kind of an earlier onset, right? Versus a late onset where memory problems kind of start in 70s or 80s or even later, right? So kind of divide dementias up into those two categories. A genetic component, we get more concerned about that in the earlier onset cases, because there's three genes in particular. There's what's called an APP, an amyloid precursor protein. And then two genes, PSIN1 and PSIN2, that are associated with kind of those early onset conditions. So a family history of kind of early onset dementias, and if you're noticing changes in your thinking, you want to make sure your doctor's aware of that family history. Later onset conditions, like the most common thing we see is late onset Alzheimer's disease, where you have memory problems start in the late 60s, 70s, 80s, that sort of thing. There is a genetic risk factor there, but it's not like blonde hair and blue eyes, right? It's not like a sure thing that you'll develop a dementia if someone in your family has a late life dementia, even if you have very similar genetics. And we'll give a specific example of that in a second. We don't generally recommend genetic testing routinely, except with a few conditions. Like there's a movement and cognitive disorder called Huntington's disease that usually most of the time specialists will order genetic testing for. With commercial DNA tests coming out, there is one of the genes for late life Alzheimer's disease, ApoE4, that is routinely screened for in some of these. But again, because that gene only gives a relative risk and is not kind of destiny and is not really diagnostic in its own right, it generally steer people away from pursuing on their own genetic testing. Or if you've had it, you've seen it as part of a commercial genetic test. Again, I wouldn't necessarily lose a great deal of sleep about that, because it's a risk factor among a lot of risk factors here. Okay, so for example, like ApoE4, which is the most common gene that you'll see kind of thrown around for late life Alzheimer's disease, it confers a relative risk. So like the average 65-year-old has about a 2% risk of developing Alzheimer's, right? And that may go up to like 2.5% if you're ApoE44. So that's like 30% increase, right? But it's a relative increase. It's not quite what some of the headlines or some of the test makers might make you think about. So, and then for that's just for Alzheimer's. When you start looking at things like Parkinson's disease, there's a really confusing kind of mishmash of things that may increase your risk and decrease your risk. Most cases are idiopathic, but there may be some overlap in some cases. So the genetics of dementia, particularly late life dementia, are pretty complex. I wouldn't take it to the bank unless you're worried about kind of an early onset family history. Those you want to talk about with your doctor. But otherwise, just know that your genes aren't necessarily destiny whenever it comes to your risk of dementia if you have a family history here. So there's a few websites out here that are pretty good. Again, this health.harvard.edu. If you Google Harvard Health and genetics and Alzheimer's, it should pull up here. Great read, easy, straightforward. The National Institutes of Aging also has a good fact sheet up on this, and there's lots of good information to read out there on this particular topic. Okay, another very common question that I get asked is, I saw an ad that if I take this over-the-counter pill, it's going to fix my memory. So what do you think about that? Okay, and without delving into specifics here, all right, for the kind of the over-the-counter kind of memory supplements, those aren't things that generally we recommend, mainly because there's not a ton of evidence, or the evidence that's out there is kind of biased, either from kind of animal studies or from kind of trials with questionable kind of endpoints and those sorts of things. I think there is a role, and we'll talk about the role of nutrition and these sorts of things here. I think what you eat and managing things, particularly your heart health equals brain health, right? I think that is super important. And we know that if things are low, if things are abnormal, particularly things like B12, right? If you're low on those things, by all means, supplement them, right? You can measure, you can supplement, you can see if your levels are going back up. if your thyroid's off the same sort of way, those things can and do influence your thinking. So if there's a defined abnormality, supplementing that is a good idea, okay? The problem with a lot of supplements, though, is that, first of all, your gut likes to kind of get to homeostasis. In other words, if there's too much of something in your bloodstream or in your gut, you have wonderful filters that tend to try to filter that stuff out and don't let it get there. Or you have things like the blood-brain barrier that actively try to keep stuff out of the brain. So not everything may pass over and influence the brain. It's actually kind of hard to get stuff into the brain. Again, I tend to be skeptical. That being said, there's a lot of research on this area. There are some things like vitamin E and antioxidants that either alone or in combination with other dietary things, I think might have some benefit. But those studies are really hard to do because so many other factors go into diet and exercise and kind of healthy lifestyle. So again, this slide changes a little bit year to year as I give this talk, but I still haven't seen kind of a slam dunk, if I just take this one thing every day, I'll never develop memory problems. I haven't been convinced enough by anything I've read so far to start taking anything myself. So there you go. Okay, related to that, a new slide, a new question that has come up in recent years is there was earlier this year a lot of excitement about a new medication that got FDA approved called aducanumab. So what's the deal with that, or Aduhelm? And so these are really exciting medications that have been trialed and developed for a lot of for a number of years here. And they focus on helping the brain clear one of those two proteins. I told you there were two things that caused Alzheimer's: beta amyloid and tau. And these Aduhelm medications help kind of clear that amyloid out of the brain. And you can see it. They do a good job of clearing amyloid out of the brain. The only problem is that in the initial data and kind of trial designs, there were a lot of unanswered questions because the trials were stopped early. So there was questions about how much benefit can someone actually expect? Who is the right person for? What are the side effect risks? There were a lot of unanswered questions. One of the biggest unanswered questions is that it was kind of got this FDA emergency authorization, this pathway forward for approval, but it was really unclear who was going to pay for it and how it was going to get reimbursed. And so this is one of those things that I'm excited about with an asterisk. I'm glad there's new tools in the toolbox, but there's still a lot more data that needs to be gathered to help us figure out, who's going to get it, and even just the pragmatics of how does it get paid for, and who is the right person for, and how do we counsel you about what to expect with this sort of thing. So it is exciting. I'm glad things are moving forward, but if that excitement is tempered with some asterisks, that's because it's a new thing, and everybody's trying to figure out how best to use it. Another question I get asked all the time is, okay, so you said there's not a magic pill out there for me. You said that, hey, there's some genes that contribute, but there's not a sure thing with any of these gene things. So what can I do to lower my risk of dementia? All right. And the good news is there is stuff you can do. All right. But it is the sort of stuff that you've heard before. But sometimes the best lessons need to be heard many, many times. All right. So we talk a lot in our clinic, and we kind of summarize the 6 pillars of brain health. Right. And these are kind of, in our experiences, the 6 most important things if you really want to make a difference in your cognitive health. And that means increase your risk of avoiding cognitive impairment and dementia, or even if you have it, to reduce your risk of decline or slow the process down. These things do work. All right. And the first thing is physical exercise. Your brain is a part of your body. And so when you exercise, you release a whole cascade of chemical changes in your brain that seem to be beneficial. There was one study that I love out of Pittsburgh that assigned older adults into different groups. One, they did their usual activities. The other, they tried to add 30 minutes, 3 to 5 times a week of walking. It doesn't have to be that extreme. Walking, right? At the end of the 6-month follow-up, the group that was assigned extra walking showed growth, showed expansion, bigger hippocampi, the memory parts of the brain, right? They changed their brain as opposed to the group without. You saw slow loss of those volumes in the brain. So physical exercise is good for the brain. As you age, there's other kind of mobility problems that can come up, right? It can be water aerobics, it can be sit and be fit exercises, it can be a hand cycle if you can't walk. But again, one of the primary things you can do to help your brain is use your body, okay? We talked about the food and nutrition thing. Even though there's not kind of a magic bullet, and some things like antioxidants stuff may be helpful, there is something about heart healthy brain, right? Heart health equals brain health. So eating your veggies, reducing your processed foods, managing your hypertension, diabetes, those sorts of things have protective effects for the brain as well. And that ties into the next part. Hypertension, hyperlipidemia, diabetes, heart health is brain health, right? And so you want to kind of manage those health factors as well. Sleep. Sleep is hugely important. And as your brain ages, sleep is one of those things that gets harder to do, or you may be sleeping longer, but you may be up and down a lot, having to go to the bathroom, those sorts of things. So working on sleep, even though you're retired and you may not have to keep kind of a set schedule, trying to get a common bedtime and wake time going for yourself, practicing relaxation, mindfulness, meditation, these sorts of things to reduce your stress level, that is associated with better long-term cognitive impairment, or reducing your odds of long-term cognitive impairment. And then mental activity. Use it or lose it, right? And so these are things like reading, games, puzzles, anything that is not passive, anything that's kind of actively engaging your brain seems to be associated with beneficial effects. And along with that is the social component. Brains need other brains. People need people. And so those that are social, those that are engaged socially tend to have less risk of developing dementia. And if they do develop it, they tend to decline more slowly. So those are kind of behavioral things that you've probably been counseled about for your heart health or your diabetes risk or those sorts of things as well. But they're important for your brain as well. Last couple of questions that we tend to tackle here is a lot of people are helping someone who has a memory problem, okay? And with that can come a lot of fatigue, a lot of stress. It's stressful to care for someone. So what should I do if I'm caring for someone who has memory problems? And one of the things that I like to tell folks is that life sometimes is a lot like an airplane flight, right? So when you get on the airplane and they're giving you the obligatory kind of safety lecture at the beginning of the flight, they say, if the oxygen mask deploy, put on your own mask before you try to help the person next to you. All right. And I think this is hugely important for caregivers, right? I'm a caregiver as well, not for someone with dementia, but I have a special needs son. And so my wife and I, we tell this to each other all the time. We got to engage in self-care, because if we take care of ourselves, we're better able to take care of him. So you engaging in self-care for yourself is not selfish, right? It helps you better take care of the person when you come back, okay? And so that sort of idea, that kind of a swap for a lot of people is the idea that by taking care of yourself, you're better able to take care of the person with memory complaints. But it's really true. We know that quality of life and health outcomes are better when a care partner is not burnt out and distressed. All right. So what does that mean pragmatically? Get help before you have to have help, right? I see a lot of families where they're not going to have anybody in the house because it might be upsetting until the caregiver falls and has to have a hip surgery or something like that. You want to be preventative, right? You want to avoid getting to the point where there's all bets are off, right? So get respite care, find a respite group, those sorts of things. As the pandemic winds down, check with Area Agency on Aging, Capital Area Alzheimer's Association, find local respite groups and get plugged in with those so that there's a standing couple of hours every other week that you are able to kind of do things. Think ahead, right? If you get a diagnosis of one of these impairments, say, okay, there's some risk for changes over time. What are we and what are the family going to do to approach these sorts of problems? Have those conversations before you have to. A lot of people are worried about being burdens to their family, but I guarantee you that your family will be concerned about you. And if you don't talk about it, their concerns will just stay inside. So talk about what your long-term plan is if you have one of these diagnoses. But do those things to try to avoid burnout. Don't just wait for things to come up and get you at the end. I think the other thing, if you're a caregiver, one of the hardest skills to learn, especially if you've been married to somebody for 40, 50 years, you've lived your life together and you're seeing these memory changes. The tendency is to kind of want to re-explain things or redirect or I hear people say, oh, they're just in denial about their memory problem. But somebody who has a true memory problem tends to forget what they forgot. All right. And so saying things like, we already talked about that. Don't you remember? Or why are you saying that? That doesn't make any sense, right? Those sorts of statements make you upset, right? Because you're upset by the situation, but also can tend to make the person who has the memory problem upset because they don't remember it or they get defensive about those sorts of things. And then as that situation escalates, more confusion, more irritability can kind of set in. So instead of kind of doing those things, if you're stuck in one of those loops of kind of repetitive questionings or forgetfulness, sometimes it's helpful to kind of move the conversation or do redirect to a different topic. One of the weird things about the brain is that old memories from 50 years ago, are easier to process than new memories, things from 15 minutes ago. And so having photo albums, having a tablet with older pictures on it and saying, oh, okay, well, we don't need to talk about that now. Hey, I came across this picture the other day, from back in the day. Let's talk about that. Try to get the brain back into kind of comfortable territory of things to talk about can sometimes be a helpful way to diffuse those sorts of conversations. So those things, getting respite, making sure you carve out time for yourself and trying to redirect as opposed to argue where you can. Those skill sets, while easy to say and hard to do in the real world, are associated with kind of less stress and more life satisfaction here. All right, so we'll, for once in my life, I gave this talk without going too long here. So I'll hit my last question here. Where do you go and learn about more? And so there's a lot of information out there on the internet and those sorts of things. But the kind of two places I'd point you at to start with, the Alzheimer's Association. Their website's great. Their stuff's evidence-based. It's vetted. It's a good place to start with. The National Institutes on Aging, nia.nih.gov, has a lot of good evidence-based information as well. Pretty accessible things. So these websites I really like if for all sorts of questions. Be cautious about things because, again, there's a lot of information, a lot of marketing on the internet, and shoot for places that have a good evidence base behind them. And then just to summarize, if you or someone you love needs care, start with your primary care provider. And we've got the contact information for CMC, the clinic that we're at, and UT Health Austin as well, if we can help as well. All right, so that was the 10 things talk for this year. May change